I'm going to talk around some of the issues around the time of diagnosis and the early management of epilepsy, and then Sophie's going to say something about more recent advances, and I think more of a focus on more difficult epilepsy. And from a point of view of first seizures, they're a very common thing. We see people with first seizures very frequently in emergency departments and in neurology clinics. And there's been a tendency, as epilepsy services have been developed, to focus very much on the kind of refractory epilepsy and not necessarily to offer comprehensive services to people right at the start of their journey. And what I would make the case for is that we need services that are comprehensive, and we need to be able to see people rapidly after their first seizure so that we can be confident they have had a seizure and give them the right advice and make sure that we start treatment appropriately in a timely manner. And we haven't always been able to do that. And certainly from a kind of a UK perspective, we continue to struggle to see people within a small number of weeks after their first seizure and get things right. But we're increasingly focusing on getting this end of the patient pathway right, as well as focusing on some of the services that we need to be offering for people with really quite challenging epilepsy. I've got a few graphs in my presentation, and I hope that's okay. One thing to say is that the first seizures can happen at absolutely any time in a person's life. And they will occur more commonly in children, as you can hopefully see on the graph here, and in the elderly. And this graph is from research that covers data that was collected in the early to mid part of the 20th century. And if we were to do this again, the graph would look different in that there would be even more elderly people presenting with seizures. So often we think about epilepsy as a condition that starts in childhood, and it very commonly does start in childhood, but increasingly there are more elderly people presenting with seizures, and our services at the moment aren't as well geared up for seeing more elderly people starting with seizures. Our populations are getting older, and we need to be also thinking about how we provide the services that people need. And I'm going to address a few simple but yet beguilingly complicated questions during the course of the next 20 minutes or so. So it might seem a really simple question to ask, well, has the person had a seizure? Has the episode that took them to the emergency department been a seizure? But that can be quite complicated and difficult for a clinician to be really sure about. And if people have had 4 or 5 episodes, we've got a good story of 4 or 5 episodes, and we can become more confident about what those episodes have been. When somebody's had just one episode, there's always a degree of uncertainty as to whether people have had a seizure, which is why it's really important that people with their first blackout, their first possible seizure, get to see somebody with the experience to make that judgment. Has it been a seizure or hasn't it been a seizure? So one of the more important things that I do when I see people in my first seizure clinic is to tell them they haven't had a seizure. They can have their driving license back, and they can get back to work and do all the things that the person in the emergency department have told them that they can't do. But also, it's important that I'm able to diagnose when people have had a seizure and put them on the right pathway. And what's mission critical, what's absolutely vital for making that diagnosis of a seizure is having a good eyewitness description of what happened. And of course, seizures don't always happen when there's an eyewitness around, and people don't always think to bring their eyewitness to them within clinic. So I spend a lot of time in clinic phoning around trying to get eyewitness descriptions to help me be more confident about what it is that's happened to the person. And we sometimes we'll often organise investigations such as a brain scan and an EEG, but they're often unhelpful in adult neurology to help us work out whether somebody's had a seizure, because often the investigations will be normal, even though the person's had a seizure. And sometimes after the consultation, we're just uncertain, and we have to be honest and upfront about that uncertainty and wait to see what happens. Obviously reassured often by the fact that investigations are normal. But we can look for clues, and we look for clues. Are there things in the patient's story that tell us actually they've been having minor seizures, maybe myoclonic jerks or other minor seizures, or auras, to give us a clue that the person might have epilepsy rather than just having a first seizure. But we often have a lot of uncertainty, and it's really important that we communicate that uncertainty and we manage that uncertainty. And if somebody has had a first seizure, of course, a really important question is, well, am I going to have another? And frustratingly, we can give people a ballpark figure and say your risk of another seizure is probably about 40 to 50% over the next couple of years. And there's been a lot of research done following up populations of people with first seizures that give us a relatively good answer to that question. But of course, what we'd really like to do is to be able to predict reliably who is and who isn't going to have another seizure. So often in the clinic, we're able to say to people, your risk of another seizure is about 50-50. It'd be great if we could say to people, your risk of another seizure is about 90%, because if it's really high, like 90%, then conversations about starting treatment become easy, because most people would want to think about starting treatment if their risk of another seizure was 90%. If their risk is 10%, if we're able to say your risk is really low, then that's also easy, because we can get people back driving more quickly, and we don't worry about the need to start treatment. So one of the really important things that we need to be able to do as we move forward is to develop the tests and understand what are the things that are going to help us to refine that prediction, so that we can counsel people much better, give them a better idea as to whether they're more likely to have a seizure or less likely to have a seizure after their first seizure. So this is going to require ongoing studies where we recruit people with first seizures, and we collect information and potentially biological samples, blood, DNA. You're going to hear about all sorts of new technologies later on, but we need to be applying those technologies at the start of people's journey as well, so that we can more reliably predict what's going to happen to them, and hopefully understand a little bit more about what has really happened in their brain to make them susceptible to seizures, so that we can think about what are the treatments that we might develop to cure their epilepsy and stop them having seizures in the future. So one of the things that we've led from Liverpool is big clinical trials that have tried to inform treatments, or rather inform decisions about what we should do, and they're quite simple questions that we've addressed. But answering simple questions is often quite complicated and challenging. So one question is whether we should start treatment for people after a first seizure, and I've already highlighted some of the difficulties there. But I'm just going to hopefully take you through some of the approaches that we have to undertaking clinical trials to answer questions. And often for situations like when people have had a first seizure, we've got a risk-benefit situation to consider. And from the point of view of benefit, if we want benefit from a treatment in this situation, we're hoping that a treatment's going to reduce the risk of more seizures, and it's going to improve the long-term outcome. It's going to put people's seizures into remission. But treatments come with side effects, so there's a balance to this benefit, and we also need to think about, well, how do we measure this benefit, this risk-benefit ratio? How do we know whether we're doing the right thing? And ultimately, we're trying to improve people's quality of life. So we need to know, does starting treatment after a first seizure actually improve the quality of life of people that start that treatment. And the way we approach answering these sorts of questions is to undertake what we call a randomized controlled trial, and the diagram tries to illustrate our approach here. So we have people that have had first seizures, and we ask them if they'd be interested in joining a randomized controlled trial, and they and a number will give consent to do that. And if they join the trial, then they'll either get the treatment, which in this situation would be anti-seizure medication, or they wouldn't get the treatment. We'd have a control group. And the way this is done is what's called randomized. It's a bit like rolling a dice. You agree to join the trial, then the electronic dice is rolled, and a decision is made whether you join the treatment group or whether you join the control group. And then we can follow people up for a few years and then see what happened. Did the people that got the treatment do better, or did the people that were in the control group do better? And we ran one of these big clinical trials trying to answer this question: should we start treatment after a first seizure should we start treatment when people have had a first seizure? And this was at a time when there was concern that if we don't do that, we might be disadvantaging people. And what we found was actually the effective treatment was small. We needed, so I was trying to illustrate that on the graph here. We've got years along the bottom here, and the number of people having a recurrence coming up the graph here, and we've got a red line for delay and a blue line for start. Bottom line is that starting treatment only actually had a small effect. It only reduced the risk of people having another seizure by a small amount. And so for people that had only a single seizure when they joined the trial, we've got a difference of 10% at 2 years. And what does that mean? That means that we need to treat about 10 people to prevent one person having a seizure recurrence. And I think that number kind of highlights the size, the effect of the treatment is actually relatively small, and we may be exposing people to side effects they might not need. And if we then looked at the number, what was happening in the long term, were people entering a remission from their seizures more quickly if they started treatment? And the answer is yes, but the treatment effect was really small. And then when we looked at the quality of life of people, we realized that actually quality of life wasn't better for those that started treatment. It was actually imbalance. And what we find was that whilst preventing seizures in a small number of people did improve quality of life from that perspective, that was completely balanced by the fact that we were causing side effects and also giving people the stigma. People perceive the stigma of having epilepsy associated with starting treatment. So the bottom line is that this trial gave us really helpful evidence to tell us that most people don't need to start treatment after they've had a single seizure. Clearly, we need to be able to identify those people that have got the really high risk of seizures now, because if we can identify those people that have got an 80 or 90% chance of having a seizure recurrence, then that's the group of people that might be more willing to start treatment after their first seizure. So we need to continue to do the research to try and understand how do we predict who is at really high risk of seizures after their first seizure, so that we can better inform our treatment decisions. Just check I'm not about to be thrown off the stage. How are we doing? We're okay for time. Okay. So
I have a microphone too, by the way.
Pardon? You're in control of the microphone as well. Okay. And is there a trap door as well?
We'll find out in a few minutes.
So again, I'm an adult neurologist, and one of the really important questions that we deal with all the time is around driving. And as soon as people have had a first seizure or a blackout that might have been a seizure, they are prevented from driving. And this is a really big issue. And in the UK, Ireland, most countries, we now think about driving as being a right. And we've got to have a really good reason for stopping people from driving. And we've got a really difficult balancing act here. On the one hand, we've got the rights of the individual to live their life and function in society. And on the other hand, we've got theirs and public safety. So somehow we need to make a decision about when is it safe for people that have had seizures and blackouts to get back behind the wheel of a car. And there was a process that I was involved in about 15 years ago where there was a harmonisation of driving regulation across European member states. So we were in a position where some regulators were quite restrictive, and the UK was probably one of the more restrictive, and countries in the EU where the regulations were pretty lax, and there were people were getting licenses in pretty lax countries and then driving in countries where there were more severe regulations, and it was causing a lot of consternation or upset, and it seemed very sensible to harmonise the driving regulations so that it's a level playing field mainly across Europe, although it's not completely level, as I'll show you later on. It's a numbers game, and I apologise for that, but there needs to be a judgment about what level of risk is acceptable to society, what level of risk is acceptable, what level of risk of seizure is acceptable to allow somebody to get driving, because the level of nobody is ever at zero risk of having a seizure. I'm not at zero risk of having a seizure. Nobody is at zero risk of having a seizure. We've all got a risk of having a seizure. But what level of risk is acceptable to allow people to drive a car or other vehicle? The general view is that if your risk of a seizure in the next year is less than 20%, you're allowed to drive a car. And if your risk of a seizure in the next year is less than 2%, you're allowed to drive a bus or a lorry or an HGV vehicle. This is completely arbitrary. There is some science behind it to back it up, but they are the standards that most of the driving regulators work towards. I realise I should have changed the title on the top of this slide. I'm sorry about that. But so what I'm going to try to illustrate here is that when people have had a first seizure, their risk of another one isn't constant. Okay. So the longer you go without another seizure, the smaller your risk of another one is. I hope that kind of makes sense. So we've got a driver here, and he's saying, well, okay, so when does my risk drop below 20%? And what I've tried to do is illustrate on the graph here again, so that if we've had a first seizure, the longer we go without another one, the smaller our risk of having another one is coming. So the question is, well, how long do I have to wait after a first seizure before my risk is low enough for me to start driving? So that's here. You know, if we've got this horizontal line is 20%. What's the time period? And it's around 6 months. It's somewhere between 6 and 12 months for most people that have had a first seizure. So this is what the European Union driving regulator says, is that basically after a first seizure, people can drive once they've been 6 months without a seizure, and they might actually be able to get on the road sooner if they're viewed to have a lower risk, although it's very difficult, I think, for clinicians to make a judgment as to who really is at lower risk given our degree of uncertainty. But it's 6 months is what the European Union says. And from the European Union regulation point of view, they've set the standard. No country can be more lenient than that, but countries can be more conservative than that, provided they can justify it. So the UK is actually more conservative than that. So the UK says that you can drive if you've been 6 months without a seizure, provided there aren't risk factors that tell us that you should wait for 12 months. So if people have got an abnormal EEG and they've got an abnormal brain scan, they need to wait 12 months after a first seizure in the UK. So hopefully that illustrates that explains why the driving regulations are what they are. And the same approach is taken for people with epilepsy that have had multiple seizures but then are on treatment and their seizures have stopped. And for people with epilepsy, the rules are that you'll need to wait 12 months. If you go 12 months without a seizure, then you're able to drive a car. If you've got epilepsy and you want to drive an HGV or a bus, then the rules are much more strict. And the rules are that you need to be 10 years off treatment and seizure-free before you can drive a bus or a lorry. So when we diagnose epilepsy in people that drive for a living, they're HGV drivers or bus drivers, then it's very difficult to get those individuals back to working and need to think about different occupations. We're okay for another few minutes, aren't we? Yeah. Okay. So I'm just going to go a bit further along the patient journey. So we've thought about first seizures. Should we start treatment? And can we drive? Thinking about some of the risk aspects. And if we go move a bit further along the patient journey, people have had more seizures. Then we need to be thinking about, well, what treatments should we start? And in my career in epilepsy, we have developed 30 plus new treatments for epilepsy. They're all on the market. We can prescribe them. But the question is, which of these drugs are actually the best for patients? Which of them are most effective and cause the fewest side effects? Which ones should we be choosing as first-line treatments? Because some of those treatments that we've developed actually aren't very good at stopping seizures. They don't help that many people. And some of them are quite powerful and cause a load of side effects, and they might not actually be the best choice for people with a new diagnosis of epilepsy. So a lot of my career has focused on, again, running randomized controlled trials, big studies to try and answer this question: which treatments should we actually be using as a first-line treatment? So again, we're in the business of doing these randomized controlled trials, and here the treatment group might be the new drug, and the control group might be the standard drug. So 15 years ago, we ran a trial which told us that actually we should be using lamotrigine rather than carbamazepine as a first-line treatment for most people with focal epilepsy. And then we have new drugs like levetiracetam, which have become available, and we have a really important question: should we be using levetiracetam or lamotrigine as first-line treatments? And we address this question in a big randomized controlled trial of people with newly diagnosed focal epilepsy. And again, sorry, it's another graph, but this told us that actually, although levetiracetam was being used very widely in clinical practice, it turned out that it's probably not the best choice for most people. It's probably not quite as effective as lamotrigine, and it also causes more side effects. And we'd kind of become accustomed to the fact that levetiracetam probably doesn't cause many side effects, but you only find what you're looking for. And if you're looking for kind of the dizziness, blurred vision, tiredness, the sort of side effects that you might expect with some of the standard treatments that we've been using for a long time, you're not going to find that with levetiracetam, because what you are going to find is mood disturbance, agitation, and more in the way of psychological side effects. And what you find actually is that levetiracetam causes more side effects than lamotrigine and isn't quite as good at controlling seizures, so we shouldn't really be using levetiracetam as a first-line treatment unless we've really thought about it and can justify why we are doing that. And we also had a very similar question for people with a newly diagnosed generalized epilepsy. We know that valproate is a really good treatment in this situation, but it comes with some problems that we'll discuss in a moment. And again, should a treatment like levetiracetam become the first-line treatment? So if we do a randomized controlled trial where half get levetiracetam, half get valproate, we can compare the treatments. And what we see, again, is that valproate is much more effective than levetiracetam. So if we're just thinking about the effectiveness of treatments, then we should be thinking about valproate as a first-line treatment for our patients with generalized epilepsy. And actually, valproate and levetiracetam pretty similar in the number of side effects that they cause. So if we just put our blinkers on and think about the results of a clinical trial like this, we come up with an answer that valproate, yeah, definitely the most effective, and we should be thinking about it as a first-line treatment. But of course, life is never that simple. And valproate also comes with some harms. Valproate is a medicine which we have lots of concern about its use in pregnancy, and for a long time we've had a pregnancy prevention scheme in place trying to avoid babies being exposed to valproate whilst they're in the womb. So we've now got another really tricky benefit-risk balance to make. What should we be prescribing for women? Should we be prescribing the most effective drug, or should we be prescribing a drug which is less effective but safer in pregnancy? And this is really difficult to make the right judgment. And of course, the regulators, the European Union regulators and the UK regulators have actually made some decisions. And we're also quite increasingly worried about the effect of sodium valproate for men. We've known for a long time that it reduces male fertility. We don't actually know how much it reduces male fertility, but we know that it can have some effect on male fertility. We've not actually, I don't think it's clear that we've not been talking to men about this as much, because I think we've been just focused so much on trying to get it right in women, but it's really important that we focus more on men as well. And recently we've got this concern that sodium valproate might actually cause harm to children born to men whilst they're taking it. The question's been raised, it hasn't been proven, but it's important that we have a conversation with men and say that this possibility has been raised. We don't know whether it's true, but you need to know about it.
Sorry, Professor, could I just ask you, with sodium valproate, okay, that's Epilim, so over here we would be very much used to the medical, or the brand name, let's say, of the medication. So just going back the couple of slides for the zonisamide and all of them, so like what would the brand names be for that, just for people in the room that might be wondering?
Yes, sorry, so I am cultured to not use brand names. We don't use brand names because if we prescribe brand names, then we cost our health service an outrageous amount of money. So Zonegran is zonisamide and Keppra is levetiracetam. And this is my last slide. So
you're okay. Thanks very much.
So what I was going to say is that we've got a real challenge to get this right for men and women with epilepsy, getting this balance between controlling their epilepsy, because not controlling people's epilepsy is a bad thing, but clearly exposing babies to medications in utero is also a bad thing. And how do we get that right? When we're starting treatment with valproate, it's often in young women that aren't planning a pregnancy. They'd much rather get driving, get their education sorted out and live their life. You know, should we be denying people access to an effective treatment for their epilepsy? It's really challenging, but on the whole, we're tending not to start valproate for women, and increasingly we may not be starting as much valproate for men, but we really need to get this right. Okay, thanks for your attention.